For anybody else in the panel, any other tips you guys would have for patients with, should you revise maybe perhaps that trabeculectomy like you showed, Tom, before you go in to do the cataract? I mean, is there many patients that have these older avascular blebs which we're trying to move away from now? So what do you think, going in first or?
Right, although that patient was terrific preoperatively. I messed it up, frankly. I should have maybe had a lower infusion pressure or something, or maybe it was just so weak that it was going to happen one way or the other. I think you just have to be aware of the possibility. But that doesn't typically happen. I can't recall that happening in the past, which is why I still have that fairly old video.
Anybody else in the panel, any other tips to prevent that kind of a problem?
Well, one thing I like to do is I like to put OVD right into the bleb. So if it's pointed right at the start of the cataract surgery, point up to the bleb. And the other thing is, if it's a really tight, thin bleb, then sometimes I'll go ahead and needle it before actually doing the cataract surgery itself, just to give a different outflow pathway.
So entering posteriorly and trying to expand the flow so that it is,
right.
So it doesn't
through
have
the
this
capsule.
focal pressure on that one side?
Right.
Okay. Anybody else?
So one trick that I've used for those who've had a trabeculectomy to help me determine if I'm going to do something to that bleb, we use trypan blue for the cataract. If we see good trypan blue trackage through the bleb and got a nice blue bleb, those are blebs I'll probably leave alone. If you see that the trypan is not tracking through the bleb, then I will usually touch the bleb with a revision, either needling or maybe an open revision. So that's one little pearl I've used trying to determine the health of that bleb.
And so for Tom's case, there was a lot of trypan in that bleb. So it's the opposite of what you're saying, right, Leon? So you know that perhaps that trypan is leaking almost through. All right, excellent. Okay, so we're going to move on to the next set, and this is going to be cataract surgery that's combined with minimally invasive glaucoma surgery in eyes with controlled glaucoma. So could I get the first ARS question before Paul speaks? This is question number 2. So this is a 75-year-old healthy patient with moderate glaucoma, visual fields about -7.5 decibels, status post trabeculectomy with mitomycin C 5 years ago, diffuse blebs, slight avascularity, now with pressures that are at 13, but requiring 3 topical medications, dorzolamide, timolol, and latanoprost, who presents with visually significant cataracts. What would you recommend? Would you recommend cataract surgery alone, quote unquote, leave well enough alone, or cataract surgery plus MIGS? Let's make things better and lessen medication burden. Okay, so 2/3 of you guys would do